So I would like to invite our first speaker for the day, Mathew sir. So we start the first talk with hitting the bullseye, effective lens position and the factors affecting it. Over to you, sir.
So hitting the bullseye, I think, is something that all of us desire, but we don't hit the target as often as we desire. What I will do is to present a paper that we presented some time back, and there is no financial interest in anything that is there in this presentation. So measurement, we have sort of improved, and the formulas also we have improved. And the history is that, from the mid-60s onwards, this has gone on. And improving measurements, we have sort of, I think, reached a kind of limit in how accurate we can get. And in using the appropriate formula also, we have sort of reached a limit. And understanding the geometry of the eye, we realize now why no single formula is good enough. And in order to tweak the results, there were optimized lens constants, and Wolfgang Hagitz came up with the ULIB website. Of course, uncomplicated surgery underlies all these things with IOL implanted in the bag with a round central capsulorhexis, which is facilitated today by flax when we have it. Measuring the postoperative spherical equivalent is very critical, and it should be done in an accurate manner. Improvements in IOL power calculations in the recent years have been due to primarily the improved predictability of the effective lens position. And as a result, many formulae are available, and these are more accurate in the newer formulae, are more accurate in the different anterior segment types. All right, so Dr. Holliday was the first person to come up with this formula for the ELP. And what does the ELP do? When the effective lens position is equal to the achieved lens position, that is preoperatively what is planned is equal to what is achieved, you get emetropia. And if the lens is more anteriorly placed than what the formula wanted you to do, then you get a myopic refractive error, and we need to reduce the IOL power in these kind of situations. And if the IOL is placed deeper, it increases the increase in the IOL power will make the patient emetropic. Otherwise, there is a hyperopic error. So our study aimed to measure the variability in pseudophakic lens position and its impact on the postoperative refraction and normalize according to the Holliday schema. So this was a single-arm interventional case series, consecutive patients with uncomplicated cataract willing to enroll. And the inclusion criteria were normal by the Holliday criteria, that is 20 to 26 millimeters, wide to wide 1075 to 13 millimeters, and keratometry 41 to 47 diopters. Exclusion criteria were comorbidities, trauma, prior surgery, or one-eyed patients. Surgery was always a temporal phaco by a single surgeon with the bag in the with the IOL in the bag. Routine post-op evaluation was at 1, 7, and 5 weeks, and data for analysis was the pre-op and the 5-week post-op refractive. And at 5 week, what we did additionally for the purpose of the study was to do a biometry to look at the ELP. And this was done in a blinded fashion. Expected spherical equivalent was by the Barrett Universal 2 on the TOMI 2000 biometer. ELP was by Dr. Holliday's quadratic equation, and the achieved lens position came from the anterior segment OCT, and refraction now by experienced optometrists is accurate to within 1/8 of a diopter, and the Swepsos biometry is the gold standard for measurement. We had 51 patients, and this was calculated according to this sample size formula. And it is inferential statistics, basically tested for normality, and where there was parametric data, we did a t-test, and where it was non-parametric, we did the sign rank test and the Kruskal-Wallis for multiple measurements. So mean age of the patients included in the study was 70. 41% of the eyes were right eyes. Mean IOL power was approximately 22 diopters. Preoperative uncorrected vision was 0.6, improved to 0.12. And corrected distance acuity was 0.03, which is very good. So what changed from mean baseline was basically some cylinder and the ACD, which is basically the cataract is gone and the IOL is coming. Otherwise, there were no unexpected surprises on the pre and post keratometry. And 94.2% of the eyes were within half a diopter of emetropia. So there was significant correlation between the achieved spherical equivalent and the effective lens position. And there was a negative but insignificant correlation between the achieved spherical equivalent and the achieved lens position. ELP versus ILP was not, versus the achieved lens position was not statistically significant, and I'll explain why. Okay, these are the blind Altman plots to show that this was poor agreement. And we did a subgroup analysis by the type of lens used. We were using approximately 10 lenses of these 5 different models. And you can see that the effective lens position on some of these is irrespective of the dimensions, the power of the lens, etc., is in a very narrow range. Okay, so it is not responsive to the geometry of the eye, whereas in some eyes there is a wide variation in the effective lens position. All right. So how does that impact? Where the lens was more responsive to the geometry of the eye, we find that the effective spherical equivalent, achieved spherical equivalent, was plano or very small variation, whereas in eyes where the lens was in a fixed position compared to the eye, the variation in the refractive outcome was higher. So 2 eyes with the same axial length and keratometry may require different IOL powers for emetropia due to the differences in the actual measured distance of the lens from the cornea, and most importantly, the geometry of the lens model that we are using. The IOL power prediction curve gives the same predicted IOL power for a pair of axial lengths and corneal power measurements for a given lens constant. So what we are doing when we are optimizing or personalizing the lens constants is to look at maybe data of 30 eyes and adjust for the variability in the estimated lens position by moving the entire curve up or down. So in this kind of situation where the interquartile range is small, the emetropic spherical equivalent is close to plano, and then we just go ahead and use those lenses. Where there is a myopic or hyperopic error, we can choose to do a constant optimization by bringing the mean closer to plano. But when there is a large interquartile range on the box plot, then we are just shifting the error up and down, but we are not bringing it closer to plano. And a constant optimization in lenses like this have a limited role in improving the clinical outcomes. And the surgeon cannot improve the results further. So if I have to choose between these lenses, 1 and 2 and 3, which are in dark and light green, are the lenses which I would choose to use. Where there's a hyperopic error, I would probably shift down a little bit. And where there's a huge interquartile range, it is possible that we should think of discontinuing these lenses. And this is the understanding of the correlation between refractive outcomes and ELP, and with this one can improve the outcomes without actually calculating the ELP for all the patients. So if you look at the biometry errors, pre-optical biometry 1992 The commonest cause was the measurement error, which was axial length, and keratometry contributed 8% to the errors. But today with optical biometry, ELP has become the number one culprit. Post-op refraction by the optometrist is the number two, and the other issues have become, measurement issues have become much lesser. Limitations, inclusion criteria was only normalized, randomization was not done, and statistical method, the power was adequate only for the intention to treat analysis and not the subgroup analysis. So thin lens, effective lens position continues to be the major source of error in IOL power calculation. Thick lens achieved lens position does not correlate with the effective lens position or the achieved spherical equivalent. And models combining these two will actually, over time, help with the accuracy of refractive outcomes. I'm grateful to my team at Chaitanya Cochin for this support in doing this thing. Thank you.
Thank you so much, sir. That was a wonderful talk indeed. Do we have any questions from the audience or the panelists?
So, it's a wonderful talk, sir. Actually, yeah. So, as we know that I think we are continuously thriving, or every formula is trying to predict the effective lens position, and it's a big challenge. So one of the interesting paper which I found, can we have that on the, Amulya? Yeah. So this was an interesting paper where it looked at, after you finish the first eye, then it used the effective lens, the lens position of the first eye, and they used that as a correction factor for the second eye, and to predict or have much better accuracy for the second eye, effective lens position prediction. So I just want to comment from sir or the panelists or anybody here, like what do you think, does it make sense to go in this particular direction?
Dr. Himanshu, sir, wants to say.
I think it makes sense because each patient, we can have a different anatomy, and usually we assume that if the axial length are correlating in both eyes, keratometry is correlating between two eyes, then the other eye may behave similarly to what the previous eye would have behaved. And it surely makes sense, provided if your clinical outcome, what you got, was not optimal. Interestingly, we also have to factor in the other things like the test-retest variability of instruments. Right now, we may call company to possibly calibrate the machine, but when we talk about anything, any machine will have variability or intertest variability or test-retest variability. On a worst day, all of them combined together may fall in same direction and may add up into a thing which will be a refractive surprise. Sometimes they may cancel each other. So each one of us can actually check on our instrument, on our manpower together, what is the test-retest variability of each individual machines, which may help us to possibly optimize our outcome. As Mathew was talking about, they actually check the refraction in the steps of 0.125, right?
Yeah.
I mean, we all have that in our refraction rack. We should use refraction in steps which are smaller. And on top of that, finally, optimization of A constant, which we earlier used to do, we sort of should do it again so that we can have individual A constant which is optimized. A constant given by company is sort of an idea which we follow, but basically we have to optimize.
Absolutely, sir. I think that's a very good point, that the only one issue we have, I mean, I think it's a logistic issue for the companies also. I would really request them to put the actual power of the IOL somewhere in the corner. That will be really helpful for us. I mean, you can have it on the front, round it off, but at least in the back somewhere in terms of 0.1, exactly what the actual power of the IOL, if it's there in the back, so we can really, be more precise in terms of targeting this one. Sir, you wanted to comment?
Yeah, Dr. Naren, I think a very valid point. In fact, 99% of my learning is from the first eye. One of the reasons not to do both eyes is, beside the medical legal part, is to learn from the first eye. The placement of the lens, the post-op refraction which comes up, and how the tissues behave. I guess it's a 100% fact that from the first eye I learned to change my 0.5 diopters in the other eye.
Absolutely agreed, sir. So I think we've been, over the years, eyeballing the thing. We see the first eye and then approximately do it. So we are thinking that should we actually do it a more structured way, the formula itself, okay, you have to enter the lens position of the first eye in the formula so that it calculates for the second eye. That would be, I feel, the next, I think additional information what is given will be very nice actually.
I think we have a comment from...
Yeah, I just want to comment that ELP is more of a problem with hyperopic eyes. So as Dr. Mathew showed, 9 different types of eyes. So 73% of eyes are more in the emmetropic, where the ELP is not an issue, it's coming more in the hyperopic eyes.
So this study was purely for the normal eyes. So I haven't even done this kind of thing to see what is the variability in the hyperopic or nanophthalmic eye. Okay, so the hyperopic eye is axial length short. Nanophthalmic is a small anterior segment with a small axial length. So there the variability and the impact of ELP is going to certainly be much higher.
Much higher.
I mean, the only downside is you have to wait a month for the capsular bag to fully contract, maybe longer, to get that final ELP. You can't just wait a week.
That's exactly what I was wanting to know, sir, because you were showing 1 week, 1 month, and 3 months. Did the achieved lens position change during those time intervals?
So in terms of how much, this is 1 week, 3 week and all that was just a clinical examination. We did only the measurements
At 3 months.
at 5 weeks after the surgery. Because the logistics of blocking up the equipment for that period of time and the fatigue factor from the patient, you know, they're like, man, this fellow, what is he doing?
And as Dr. Himanshu was mentioning, even many of our biometry measurements, the ACD measurements are much more, sorry,
I'm so sorry.
much more accurate
It's
in
not
the
me, it was
normal
other
eyes, in the, that is the phakic eyes. But once we move on to the pseudophakic eyes, the pseudophakic ACD measurements itself, there is a greater extent of variability. ILMaster 700, they have claimed that it has been brought down, but many other biometry devices, the variability is much more in the pseudophakic patients.